Welcome to the 8th edition of Daniels and Worthingham's Muscle Testing Techniques of Manual Examination. This DVD is just one of numerous additions to the latest version of the book. My name is Dr. Judith Burnfield, and I've had the true pleasure and honor of developing this DVD in response to an invitation by the current authors, Dr. Helen Hislop and Jackie Montgomery. This DVD is meant to serve as a tool to assist you in developing and refining your knowledge and skills related to manual muscle testing. It is not intended to replace the book, but instead to augment your learning experience. The concepts described in the book evolved in part to address medical needs facing society, as well as from the forces that drew together the original and subsequent authors of the text. To develop an appreciation for the evolution of muscle testing techniques, Dr. Helen Hislop, a visionary educator and researcher, will provide a brief historical overview related to manual muscle testing. This is followed by an interview with Dr. Jacqueline Perry, world-renowned for her research in gait and movement analysis. Dr. Perry has been a strong, lifelong proponent for the value of manual muscle testing in guiding and refining the management of patients entrusted to our care. To assist in developing your manual muscle testing skills, master clinicians from around the country will demonstrate the techniques described in Daniels and Worthingham's book. In particular, they perform manual muscle testing procedures for evaluating strength of the neck, trunk, upper extremity, and lower extremity muscles. Additionally, the upright motor control test, a technique for assessing muscle performance in persons with central nervous system disorders, is demonstrated. Clients of varying physical abilities and statures have been filmed in an effort to demonstrate the subtleties of manual muscle testing. At the end of each DVD chapter, a clinical example section has been included to provide you with an opportunity to assess your understanding of the material. I'd like to take just a moment to acknowledge the substantial contributions of the team members who contributed to the creation of this DVD. Our expert consultants included Dr. Joanne Gronley, Dr. Helen Hislop, Jackie Montgomery, as well as Dr. Jacqueline Perry. The master clinicians who served as examiners for this DVD were the wonderful clients involved in the assessment procedures included This DVD could not have happened without the extraordinary talents and patience of Vicki Philippi, the person responsible for recording and editing the contents. A special acknowledgement related to the contributions of Nadine Wiley, Tanner Augustine, Tate Augustine, and Thad Buster are also in order for their behind-the-scenes efforts, which ensured that all went smoothly. It is now my distinct pleasure to introduce Dr. Helen Hislop, Professor and Chair Emerita of the Department of Biokinesiology and Physical Therapy at the University of Southern California. Dr. Hislop co-authored the 8th edition of Daniels and Worthingham's Muscle Testing Techniques of Manual Examination. Dr. Hislop, what an honor to have you with us today.
Thank you, Dr. Burnfield. We are so glad to be able to add this DVD to the book. Muscle testing is not something readily learned and readily achieved. The purpose of it is really to evaluate patients' muscle strength and be able to reliably and consistently follow the patient's course. In muscle testing, the further back you look at history, the further ahead you can see what is coming. Muscle testing began in 1904 in Bevor's Croonian lecture. Bevor actually established a neuro pattern for muscle function, and that was his earliest contribution because the amount of brain used for different muscles is what he was interested in. But what he did for us that was so important was he stimulated a woman named Wilhelmina Wright to become interested in muscle testing, and she happened to have been assigned to the gymnasium near Boston and another one in Vermont to work with Dr. Robert Lovett, who was the director of orthopedics and who was responsible for the care of polio children in those early epidemics in the early 1900s. And she was assigned to the gym by Dr. Lovett and asked to develop a system where they knew what muscles were doing and where they could follow the progress of their patients. She went on then to put all of these incredibly different motions, different movements, different muscles, different anatomy together in her book. She was an incredible woman, and if she were here, I would put her up for a Nobel Prize. It waited until 1928, 1929 era, when Lovett himself changed his system and created a system of muscle grading from 1 to 5, which included the effects of gravity and the effects of resistance. And the very next year, Dr. Lohman, the director of Orthopedic Hospital in Los Angeles, came up with a similar plan independently. And his plan included grades from 1 to 5 with plus and minuses for muscles above grade 1 and below grade 5. So that was really the first complete one. 1936 to 1938, Henry and Florence Kendall developed a system of muscle testing. And then in 1946, Daniels, Williams, and Worthingham came out with their contribution, which was the predecessor to the book we're talking about. The three were all at Stanford at one time, and polio was raging, and they had to do something to help the epidemics and help the PTs to treat the patients. That period led to the organization and writing of the book. Somebody asked me, how did you get on it? You know, that's one of the strangest questions in the world, but I got on it because Dr. Worthingham asked me to take over the book. And I couldn't have been more shocked, and I didn't dare say no to her, and perhaps I should have. But in any event, I did select Jacqueline Montgomery, who, to the best of my ability, was the most experienced, most knowledgeable, and competent muscle tester at Rancho Los Amigos, and she agreed to work with me on the book, and we've now done it for 3 editions. Muscle testing is not something readily learned and readily achieved. It is a procedure that you cannot learn by taking one course in school. You have to study muscle testing over a long period of time. You have to practice it. You have to listen to the pundits who know what they're doing and try to learn from their procedures and how they do it. And honestly, I may be a heretic, but I don't see any major differences in the various textbooks and materials that are out there on muscle testing. They're basically the same. If you are consistent and use the same method of testing in every patient and don't alter it, you will have at least a reliability that you can look back on and say, well, this patient has improved. And you can put some numbers on it, and you can use gravity and resistance, and you could add some statistics, and that will prove it. I'm afeared that the number of people who are expert in this are diminishing gradually. And they're diminishing gradually because of the advent of new techniques of muscle testing. But those are so expensive and require a different kind of training, such as electromyography. And they do work, but we don't have enough money to supply all of the new instrumentation required to do this. So manual muscle testing is going to be around for a long, long time. So what I say to you in conclusion here is that in addition to manual muscle testing, you have a challenge to improve what we're doing in the clinic and to use new methods while you don't ignore and forget the good, true, and tried manual muscle testing. Thank you very much.
It is now my distinct honor to introduce Dr. Jacqueline Perry, Chief Emeritus of the Pathokinesiology Laboratory at Rancho Los Amigos National Rehabilitation Center and Professor Emeritus of Orthopedic Surgery and Biokinesiology and Physical Therapy at the University of Southern California. Dr. Perry, what an honor to have you here today and to be able to hear your thoughts related to manual muscle testing and the contributions to our intervention plans with patients. Why should a therapist or a physician worry about strength?
Because all functions is competition between body weight and segment weight and muscle strength. If you don't know what the patient's strength is, you don't know what your problem is.
What level of strength do people need to be able to walk?
Well, that varies because patients adapt to weakness by going more slowly. And so they can cut down as they need to. A person with good proprioception, say as polio, can walk with very marked weakness, but really about 3+ slows them down. And if you get too slow, below about 60 meters a minute, your companions will not wait for you. 3+ is about the time that my post-polio are showing up at the clinic.
And why is that?
Well, it's only 25% of normal strength, and it has no margin for disability.
We've been talking about the lower extremities. I'd like to transition to discussion of the upper extremities. What level of strength does a person need in their arms to be able to manage in their environment, for example, for reaching into a cupboard or carrying bags?
Well, the primary demand is on the shoulder, and that'd be at least grade 4. And elbows, these elbow flexors and extensors, they're about grade 4. But they're not involved as often as the shoulder.
How about the wrists and the hands?
Well, the hands, you very seldom have a severe hand problem, and either you have hands that can grasp or they can't. And unfortunately, it doesn't happen very often. And you've got 10 digits, so they can do a lot of substituting.
Dr. Perry, with aging, it's commonly accepted that individuals lose strength. Should we adjust then our manual muscle testing grading approach with older adults so that when we test what would traditionally be considered a 4 out of 5, if a person's 90, we'll give them a 5 out of 5, knowing that they're actually a little weaker?
Not unless you get the government to slow down the traffic and lengthen the time you have to get across the street.
That would be quite a mission.
Actually, everyone has to meet the same standards of basic function, traffic, and if you can't do it, you're going to be in trouble.
So that sounds like an unequivocal, no, we shouldn't adjust our grading scale.
It's not a personality test. It's a physical mechanical test. We have to have enough to meet the mechanics that society has put out for us.
What causes a loss of strength in older adults?
In older adults, it's two things cause it. One is decreased function. They have more hobbies like sitting watching television and not wanting to walk. Or it's neurons start dropping out about age 60. And so there is a physical decline. Most of it's disuse.
What about the orthopedic patient, Dr. Perry? What contributes to weakness in the orthopedic patient?
Well, that's usually disuse weakness after surgery. Because, first of all, they've cut down on their activities with their painful joints before surgery. Then they have surgery, which makes them more disabled because they're at least 24 hours they're not walking. And they do less. And so they have a disuse problem that's not recognized. And so it takes a long time to recover it, and you really need a strengthening effort. Just walking doesn't solve it.
Do you have any clinical examples that illustrate this point?
Well, yes, I had a patient come in my lab just a couple of 3 months ago who, they came in and wanted to know what was wrong with her gait. She couldn't walk very well. And she walked about 20 meters a minute. But she'd had 2 total hips surgeries and 1 total knee in series and no rehab after it, because you can't see weakness because you've got enough padding around your muscles. You don't see atrophy. They look fine, but there's not enough muscle underneath.
And so what would be how should we approach that differently?
Well, they need to recognize that the people do less when they have painful joints before the surgery They do less after surgery, and they lose strength. And disuse weakness is a real thing. Actually, everyone who has that kind of problem should have rehab afterwards. It's a strengthening program, not just a walking program.
What are the limitations associated with manual muscle testing?
Well, manual muscle testing is a screening test, really. You can't measure more than 50% of normal strength. But that's 50% enough for routine living, so the grades of normal are fine. But the examiner has a motor is the triceps. That's not as big as the quadriceps. And so you don't have the capacity to measure more than 50% of the quads, maybe 60% of the hips, and 20% of the ankle, because the lever length that the examiner can use, the length of the bows, you have either 40 to 80 centimeter long lever for the examiner when you measure the hip. You've got a 40 centimeter lever for the knee. You've got a 10 centimeter lever for the foot. So you can't measure the ankle at all. You get 20% of normal only.
Dr. Perry, what's your take-home message for people watching this?
Know the problem you're treating by finding out what the strength is. Don't try to guess just from a watching function. I think the other thing is it's a code. It's not a numerical percentages. I'm sorry that they went to the 1, 2, 3, 4, 5. It's great for statistics, but it doesn't tell the clinician what the problem is. The original scale was poor, fair, good, and normal. And that tells you what's going on. And you really have to be good to normal to meet the demands of everyday society.
Thank you so much, Dr. Perry.
You're very welcome.